Good morning, and welcome to Ask the Doctor series here at the Cleveland Clinic. My name is Frank Caputo, and I'm the Vascular Surgery Aortic Director here at the Cleveland Clinic. I am joined by my esteemed colleagues, and I want to just notice that what makes this unique is we have multiple specialties here at the table to give you different opinions and different treatment options and how we manage things, and that's what makes this Cleveland Clinic great, is the multidisciplinary approach to disease statuses. I'm here with Dr. Scott Cameron, Dr. Pulkit Chaudhry, Dr. Ali Khalifa, and Dr. Courtney Hannock. And maybe just introduce yourselves as we go down the line real quick.
Thanks, Dr. Caputo. So my name is Scott Cameron. I'm the section head of vascular medicine, and I'm trained in cardiology as well as vascular medicine, and also have a research interest in abdominal aortic aneurysms.
I'm Pulkit Chaudhry. I am one of the vascular cardiologists here at Cleveland Clinic. I'm dual appointed in sections of vascular medicine and cardiology. And my interest is in arteriopathies, abdominal aortic aneurysms, and all over.
I'm Ali Khalifa. I'm one of the vascular surgeons here at the Cleveland Clinic, and partners with Dr. Caputo and Dr. Hannock. And obviously we see a high volume of aortic surgery.
My name is Courtney Hannock. I'm a staff vascular surgeon here at the Cleveland Clinic. Excited to treat abdominal aortic aneurysms and answer your questions today.
So what we have here is a list of questions that you guys asked, and we are here to hopefully answer them. So I'm just going to start off, Dr. Hannock, real quick. What is the difference between aortic enlargement, aneurysm? What makes an aneurysm? So maybe just give a couple definitions for us.
First, I think we need to start by defining what the abdominal aorta and the aorta in general is. So you have your heart, which is the pump, and then after that, you have a large blood vessel that sends all of the blood to the rest of the body. When we start talking about enlargement of that area, we call it ectasia is the first thing, which is where the aortic wall is a little bit larger than we expect. So there's a normal size of the aorta, and that's anything that's less than 3 centimeters. Above 3 centimeters, we start to call it an aneurysm. And I like to explain that to my patients, like instead of being a straight tube, you start to think about it like a vase. There's a tube at the top and then an outpouching at the bottom. And that outpouching can happen anywhere along the abdominal aorta. We start to classify this as an aneurysm once the wall size becomes greater than 1.5 of what we expect it to be. So an abdominal aortic aneurysm, or aneurysm in general, starts to be classified greater than 3 centimeters.
Dr. Cameron, you are a world-renowned lab on the pathogenesis of what makes an aneurysm, trying to figure out what makes them worse, what makes them better. Maybe you can go into a little detail about what are things that make an aneurysm, what are things that risk factors that we can potentially help prevent growth if we find one, maybe help prevent one if we have a family history to that effect?
That's a great question, Dr. Caputo, and it's a question that patients quite often ask us. So when I think of aneurysms, I usually tell patients that most of them happen because the artery wall becomes hardened or atherosclerotic. Those are the majority of the aneurysms that we treat. Certainly there are patients that we do find abdominal aortic aneurysms in who have connective tissue diseases, such as Marfan syndrome, Ehlers-Danlos syndrome, Lewis-Dietz syndrome, and there's some other rarer connective tissue disorders. And then very, very occasionally, we'll also find some patients that have an inflammatory disorder, such as vasculitis, Takayasu's, arteritis would be one. It's highly unusual, but we do sometimes find those. And in terms of medical management of them, the current guidelines would tell us that it's absolutely critical to have your blood pressure managed within a certain range. So we would like your blood pressure to be less than 130/80 millimeters of mercury. There are certain medications that are better than others for helping that. We want to control cholesterol levels in most patients. That's what we call a class 1 indication in a patient with an atherosclerotic aneurysm, which means it's kind of the law in medicine. We have to treat that. And then the third thing is there's an option to give patients what's called an antiplatelet therapy. So medications like aspirin or clopidogrel. That's currently a class 2B indication, which means that in certain situations it's a good idea. We wouldn't do it for all patients, but certainly taking a good look at the patient's history and then other things that are going on in their body might define which medicines we would use if they're not quite ready for surgery.
The Khalifa, you know, we often say, patient shows up, I have an aneurysm. Now what to do? What sizes do you treat? What sizes do you get worried about? And what are we worried about? What do these aneurysms, what problems do they cause that we're so concerned about fixing?
The biggest concern with abdominal aortic aneurysm is as the aorta grows, that there's weakening of the walls. And studies have shown that the risk becomes significant when the aneurysm is greater than 5.5 centimeters in men. There are some exceptions for women at 5 centimeters. Aneurysms that show rapid growth usually tell us that the wall is weaker, and over years it's growing rapidly than the annual average that we know of, which is usually somewhere around 0.4 centimeters a year. Most patients will come in, they're anxious. They've gotten the diagnosis by getting a scan or an ultrasound for some other issue, and they are afraid that they're walking around with a ticking time bomb. And I think the first thing I do is I calm them down, and we talk about the risk being a risk over a year. We gotta risk stratify, figure out how we can improve their health overwise, do all the steps that Dr. Cameron had mentioned over, and then figure out a treatment plan in the future if they do reach the criteria for repair.
Dr. Chowdhury, a lot of times our patients come in and say, my dad had an aneurysm, my mom had an aneurysm, there's some family history. In fact, there's several questions on here about family inheritance of aneurysms. Can you talk to that about a little bit? What are the risks of having aneurysms run in families? And you have a special interest in arteriopathies, and maybe go into a little bit about that and the genetic disposition about those.
Yeah, absolutely. Thank you, Dr. Caputo. Again, a fantastic question that we get asked quite a bit in our clinic. So there is definitely a family predisposition to abdominal aortic aneurysms. We know patients with a first-degree relative who has abdominal aortic aneurysm, parents, siblings, children, you have a higher risk of having an aneurysm. As you know, most aneurysms are asymptomatic, so those are patients at least above the age of 65 and a family history of an aneurysm. They should definitely be screened for an abdominal aortic aneurysm. There are genetic conditions that are specific for abdominal aortic aneurysms. Those are fairly rare. The broad spectrum, the conditions that Dr. Cameron just mentioned, vascular, Ehlers-Danlos, Loeys-Dietz syndrome, Marfan syndrome. Those are patients with those genetic conditions tend to have a higher risk of not just abdominal aortic aneurysms, but also thoracic aortic aneurysms. So patients with a history or a family member who has one of those conditions should be definitely screened for those conditions periodically.
No, I agree. I think that the whole familial genetic component of abdominal aortic aneurysms has still yet to be sussed out. I mean, I think that we know there's a connection. We just don't know what it is yet. I'm going to go down the line. The one question I get asked all the time is, and this is again right from you guys, from the patients, I have an aneurysm. What can I do? Exercise-wise, work-wise, sex-wise, what can we do physical activity-wise? Because people get scared, right? Because we know that the risk of these aneurysms that they rupture. But what do you do based on size? Do you do it based on fitness? So I'll start with you, Dr. Cameron. What do you tell your patients? What activity level should they do?
Yeah, it's an excellent practical question, actually, that patients do ask frequently. Part of the answer to that does depend on the size of the aneurysm, as Dr. Khalifi and Dr. Hanek were indicating. Certainly in the smaller aneurysms, I tell patients that they can engage in aerobic exercise just as they would as if it wasn't there. Once an aneurysm starts to get a little bit larger, so once you're into the 4 to 5 centimeter range, one of the things that I ask patients to be cognizant of is don't lift anything that would cause a lot of abdominal pressure. So more than about 40 or 50 pounds. This has been studied a few times over the years. No one can really come up with a definitive weight that would be an additional risk for patients, but certainly if someone was an elite lifter of weights, lifting 300 pounds and generating a lot of abdominal pressure, say their aneurysm was 4.55 centimeters, I would say that that's probably not a good idea, because we do have credible data that you cause an increase in what we call wall shear stress in those conditions. But then the second thing that I find quite helpful is there's a blood test available at Cleveland Clinic. I can't tell you the name of it because it's under embargo with a medical journal called JAMA. We have data coming out jointly between vascular surgery and vascular medicine, which says if we use this blood test, it actually has some predictive ability on the risk of rupture, the rate of growth, and actually if you're a patient that might need earlier surgical intervention. So I think as these blood tests sort of develop, it allows us to give patients a little clearer picture of what their treatment trajectory might be in the next few years.
Yeah, just to go back to the physical activity part of it again, very commonly asked question. So I typically would not restrict necessarily cardiovascular exercise. You know, patients like to go for walks, riding a bike, on a treadmill. I typically would say that's minimal restrictions when it comes to that. Again, when you're lifting something heavy, and I tell patients, if you're not able to have a conversation through that, if you're really holding your breath and grunting, those are the things that I would probably avoid. And then one last thing about what patients can do. It's 5 minutes into an aneurysm conversation. We've not talked about tobacco yet. So we know by far the biggest risk factor for abdominal aortic aneurysms is tobacco use. So stopping tobacco or any forms of it, of nicotine exposure, that's what I ask them to do.
Yeah, similarly, I do not discourage them from following cardiovascular activity. I think if they've been active and they've been doing, like small Swedish weights, I think that's perfectly fine as long as they continue the same rhythm. I do caution some patients that, with the diagnosis, we're trying to go from a sedentary lifestyle to running a marathon, and I do tell them, if you do want to go active, that's fine. Just build up your stamina gradually.
I also agree with the panel. I think when counseling my patients, I like to really talk about the fact that our job as medical professionals is to keep you as active doing the things that you love to do for as long as possible. And I think even when you get diagnosed with an aneurysm, ultimately that's our goal, and that's what we decide when we start to talk about different treatment options as well. So I agree. I want patients to continue to be active, to do the things they love to do, and to enjoy life until we reach that surgical decision making. And then also talk about that. As far as diet, I think that eating your regular diet that you've been eating is fine, as long as that includes some healthy options. And I think ultimately just looking out for your health, taking your medication, seeing your primary care physician, and following up with your medical specialist is what I recommend.
Yeah, I always tell my patients, you have to live life, right? You can't have a life without quality of life. So live your life, keep your activity going, and potentially just cater it to the fact that you do have this pathology of having an aneurysm. You've got an aneurysm, it meets size. When do we fix it? How do we fix it? What kind of risk stratification or how should we go about looking at these patients? I'll start off with the pre-op portion of it. I have a 5.5 centimeter aneurysm. Now what? Do I do endo versus open? And maybe I'll talk to the cardiologist first about what do you look for in those patients to help determine the healthiness of the patient?
Lots of things go into pre-op cardiovascular risk stratification. The patients who have abdominal aortic aneurysm, the vast majority of them are atherosclerotic. I tell my patients, you got plaque in the big blood vessel in your belly. Chances are you have plaque in other blood vessels of your body also. And what that means is we need to make sure that you're on appropriate medications so that not just perioperatively you have a lower risk of cardiovascular events, but long-term you have a lower risk of cardiovascular events. So I look for their immediate ability to walk up a flight of steps. We're talking about any symptoms of chest pain, shortness of breath. Are they having any of those? Things that would tell me that their heart is healthy enough to carry and to sustain the injuries or the insults will get perioperatively. We optimize their blood pressure medications, make sure they're on appropriate antiplatelet therapy, and we make sure that they're on appropriate cholesterol medications and diabetes medications perioperatively to go through surgery safely.
So yeah, I think you have to optimize these patients, not just cardiovascular, too, but also look at their lungs and look at what kind of function we're dealing with. We talk about treatment options, Dr. Khalife. We talk about endovascular versus, maybe describe what endovascular is versus open surgery.
Over the past several decades, there's a new approach that vascular surgeons have been using quite frequently, which is endovascular. The traditional open surgery, which we still do perform a lot, it entails us doing an open procedure, finding the aorta, taking out the aneurysm, getting rid of it, and replacing it with a bypass, with a plastic tubing that's sterile, that replaces and continues to carry the blood where it's supposed to go. Over the past several decades, we've been able to deliver that same plastic tubing over a stent. And what that stent does is it does not get rid of the aneurysm per se, but it excludes the blood flow into it. And the vast majority of those patients, it does promote around 70% of the aneurysm to clot off and not be a threat to rupture. And so those are the two options. And obviously they vary in complexity depending on the patient, not one size fits all.
Dr. Hanek, is one preferred over a healthy person versus a non-healthy person? Are they both the same in durability? When you're talking about endovascular, are there certain criteria that you try to hit to make sure that it's most durable as possible? Or
Yeah, so I think when talking to patients overall, you're looking at their overall, medical presentation. So are you active? Are you able to handle an open procedure? I think in an open procedure, you're accepting a little bit more of a strenuous procedure up front. So the recovery time is a little bit longer. You're getting a larger incision, but the durability of that goes into how we watch this over time. So once we do the repair, we end up doing a CAT scan a year after, and then we monitor that repair every 5 years for the rest of your life. That's recreating the tube with an open procedure. With an endovascular procedure, we look for what's called seal zones. So we need healthy aorta to put the stent graft in that Dr. Khalife was describing. And so there's a couple of criteria that you have to meet in order to be qualifying for that. And that allows us to create that seal for the longest period of time. I think with that procedure, you have less upfront hit to the body, so it's a quicker recovery time, but it does require surveillance of that area or a CAT scan or an ultrasound once a year for the rest of your life to ensure that those seal zones remain stable.
Dr. Cameron, you've done a lot of research on aneurysms. Does the aneurysm respond differently to whether we do it open or endovascular in terms of do people still, if you have an aneurysm that you fix endovascular wise and that aneurysm is not shrinking, it's not growing, what do you think is going on there on a cellular level or micro level sometimes? You don't have a leak obviously, but that aneurysm is just not shrinking.
Shrinking. Yeah, it's a great question. One of the things that I sometimes will explain to patients is that the blood vessel wall in an aneurysm already is deprived of blood flow. And so the middle part of the blood vessel wall, which contains a type of muscle, not the same muscle that we use to lift weights, of course, but a different type of muscle. And there are certain patients where that muscle is more responsive than others if you put strain on either the outside or the inside of it. And that's one of the reasons why, as you were saying, some of the aneurysms will be excluded. Sometimes they'll continue to grow. It's not infrequent, as you'll know. We'll sometimes receive patients at Cleveland Clinic who've had an endovascular procedure and it might not have gone as expected. The aneurysm continues to grow and there are complications. And having worked at a lot of different centers, one of the benefits I see is that Cleveland Clinic is very accustomed to handling those kinds of cases. But it's a hot area of research right now. I mean, it would be great, just as I mentioned, if we now have a blood test that can look at how fast aneurysms would grow. It'd be great if we could have something similar that perhaps looks at some of the proteins released into the blood from the blood vessel wall, and we'll know if that's going to be someone that will respond better with endovascular therapy or open surgery if they're qualified for either. But that's a interesting concept.
So, Dr. Chaudhry, we've talked about people presenting with an aneurysm, and there's a question: how do I know if I have an aneurysm? Right? So, we assume these patients that are coming to us already have aneurysms, but it's often an undiagnosed disease. It's a silent killer, right? So who should get screened? When should we do the screening? And should everyone just get screened at a certain age? Like, at what point what are the risk factors of having these aneurysms?
The vast majority of patients with abdominal aortic aneurysms are never going to have symptoms. So screening becomes very, very important. Biggest risk factors for screening: family history within first-degree relatives of having an aneurysm. Tobacco use at any point in your life increases your risk of having an aneurysm. So any patient who's smoked previously, has a family history, I would certainly recommend screening for those individuals. Patients, as they get older, especially above the age of 65, between 65 and 75, those are other patients that I would absolutely screen for aneurysms. Family history of other genetic conditions, such as the ones we talked about earlier, that yield in thoracic and abdominal aortic aneurysms, Marfan's, Loeys-Dietz. Those are other patients that I would look for. And then when it does come to symptoms, there are a subset of patients that will have vague symptoms of abdominal discomfort, back discomfort. Occasionally on a physical exam, if we notice a lot of pulsatility around the abdomen, those are also patients that I would definitely screen for aneurysms.
Yeah, and I think it's important to note, smoking is such a high risk factor for getting an aneurysm that, Medicare actually has a bundle that will screen a population if you've had so much smoking. And the smoking is minimal. It's like 100 cigarettes over a lifetime. So it's not a whole lot of, just to give you an idea, it's 5 packs over a lifetime. So that's not a whole lot of smoking for those that have had smokers in our family. We talked about screening, about patients, and you mentioned something about monitoring after treatment of an endovascular. So maybe you could talk about not screening, but observation or following these patients after we fix with a stent versus after we fix open-wise.
I think in general, with our patients that we see, most of the pathologies that we see in vascular surgery, vascular medicine, cardiology, you become our patients for life. So we kind of adopt you. From there, when you get an aneurysm repair, if you get an open repair, that's where we're recreating the tube with the woven stent graft that we actually sew into place. So we check to make sure that that area where we sewed into the aorta remains stable every 5 years for the rest of your life. That usually is done with a CAT scan that is followed by your vascular surgery, vascular medicine, or cardiology offices. Sometimes your primary care will order that as well. We do that to ensure that where we sewed our graft to the aorta remains stable and that there's no intervention that needs to take place there. As far as endovascular, because like Dr. Khalife said, we're excluding the aneurysm, we're not getting rid of it, we check those seal zones of the graft. So we typically do that once a year. We do it at your first month follow-up when you see us after surgery. And then once a year, we do a CAT scan or an ultrasound in the office to make sure there is no blood flow going through that aneurysm and that our seal zones look good. So the follow-up is a little different for each one and is sometimes, for lack of better terms, the selling point for choosing an open versus an endovascular repair.
It's exciting times right now to be part of aortic pathology because there's so many new advancements coming out on both the medical side of things as well as the surgical side of things. Dr. Cameron, maybe you can talk about some of the things that are coming on the horizon in terms of medical delivery of things to help retard aneurysm growth or maybe prevent aneurysms from even forming.
Yeah, it's a great question. Part of that's understanding the underlying biology, and then as Dr. Chowdhury was telling us, other things that are going on inside the patient. Dr. Chowdhury actually recently published a paper that looked at Cleveland Clinic patients over about 10 years. And one of the concerns patients will ask is, I know I have coronary artery disease, does that mean my risk will be greater for aneurysm growth and rupture? I know I have carotid disease, I know I have renal disease, I know I have disease in the legs or peripheral artery disease. And it turns out that if you have peripheral artery disease, so narrowed blood vessels in the leg, if you're not on the correct medications for that, that leads to accelerated growth of the aneurysm in the abdomen, which was a huge surprise to us. But if you take certain combinations of medications, that can slow the growth. In terms of new therapeutics, some of the data, as you know, that we've published from Cleveland Clinic has shown that aspirin over a period of time can slow the growth of aneurysms, but curiously only in males. It doesn't work in women. And so everyone has been looking for a new medication to slow the growth or cause regression of aneurysms, and we're simply not there yet. But in terms of some of the interventional therapies, I've been really excited to see at some of our conferences that we attend together. Some of the grafts that can be placed inside the aorta can release medicines that can sometimes repair an aneurysm and prevent it from becoming expansive in spite of that stent being there. So there's a lot of new technologies, and we're really fortunate at Cleveland Clinic that a lot of the companies that have invented them do tend to come to us first because they recognize, as you well know, we are a center that has a very comprehensive team and a high volume, so accustomed to seeing it.
I think that's important to ask your doctor about or ask Cleveland Clinic about is research trials. Because A, not only are you benefiting yourself, but potentially helping your aneurysm and being part of the latest cutting edge technology, but you're also helping progress a medical progression. And I think that's an important thing when you come to an academic institution here like the Cleveland Clinic. Dr. Khalife, we talked about the medical side of advancement. What about the surgical side? Not all aneurysms are 3 centimeters from the renal arteries with great landing zones. Maybe talk about some of the things that we're doing here that helps do minimally invasive treatments that are patients that are unfit for big open surgical surgery.
Not all the patients that get stent grafts understand what those stent grafts are made for, those stents that are placed. So as Dr. Hanek initially was describing, that aorta start all the way from the heart. And as we call it, the abdominal aorta, it has multiple major branches that feed your important organs, your stomach and liver, your bowel, 2 kidneys, and then the 2 legs that kind of split down to give your pelvis and your legs. And we have divided those as surgeons into zones. And depending where that healthy aorta is, the typical and standard stent graft that's done widely in the United States may not be appropriate for you because you don't have that seal zone that Dr. Hanek talked about. So at the Cleveland Clinic, we're fortunate enough to be able to do some more advanced endovascular where we use special stent grafts that allows blood flow to these important blood vessels of these organs while obtaining a larger seal zone within the healthier abdominal aorta. That increases in complexity, but thankfully we do a lot of that here as well.
Yeah, I think people have to realize if you look over the course of endovascular repair, about 40% of patients in the country stents are put in what they call off IFU or off criteria. And what we know is in those patients is a high amount of failure. So that's why we're trying to always pursue these endovascular advanced treatments to try to get to that healthy aortic zone. And we're fortunate here to be part of all the latest clinical trials of both the medical and the surgical side. Why come to the Cleveland Clinic for your aortic repair? Dr. Cameron.
One of the things that patients will consistently tell us at Cleveland Clinic is that when they're here, they feel as though they're treated as family. There are many places that physicians and surgeons can work, but working at Cleveland Clinic, it is not just a job to us. It is everything that we do, and it defines everything that we do. And because of that, when patients are not well and they come to us, as you know, we tend to take it very personally because we treat them as family members. And I think having that emotional connection to patients on top of just having medical treatment, it adds a different flavor to their treatment. And they tend to leave here with a comprehensive plan. And I know certainly you and I have shared some cases where patients have sometimes started with me and have discovered something that's very, very serious. I found you and you've said, this is a patient that we can take to the operating room in the next day or two. It's very difficult in medical institutions in the United States to have that level of collaboration where everyone understands that the patient is number 1, 2, and 3 at Cleveland Clinic.
In addition to fantastic surgeons and world-class surgeons that we have, fantastic medical doctors, and everything that Dr. Cameron said, I think the system here is also stacked to optimize patient care as best as possible. I mean, it's rare that I go through a clinic day without calling one of you guys and vice versa. So it's just this way the system is stacked is to make sure patients at the center of it and we tackle the problem from all ends.
Why come to the Cleveland Clinic? I think 2, 3 things come to mind is volume. We see a lot. Under Dr. Caputo running the Aortic Center knows we do one of the largest volumes in the US, and what that helps is it's a team sport, as everyone was alluding to. It's the anesthesiologists that take care of you, the nurses, the intensive care unit, the surgeons. Every step of that care has high volume experience in the United States. And as well as the compassion for all the patients that we see.
I would recommend that patients and family members come to the Cleveland Clinic. I think this panel is a great representation of how we have a multidisciplinary approach, mainly meaning that we're a team here. So regardless of what you come here in need of, there's a doctor here, there's a team here that can help you get that taken care of. And I think that team approach is really priceless when it comes to keeping the patient active and, like Dr. Caputo had said before, doing the things that you love to do and getting you back out there living life.
I agree with all those things. I think one of the most important things to realize by having such experts around, if something does go wrong with your aneurysm, if it does rupture and we have an emergency that comes in, or if during the surgery, we have the ability to rescue. And we have world-class people on all specialties, world-class nurses, world-class respiratory therapists, world-class everybody, that we have the ability to rescue and have great outcomes. The one thing I do want to leave off with saying is what are the warning signs of an aortic rupture? Patients always ask, and I just want to implant one thing before we leave and end this session, is I have an aneurysm, when do I know to call the doctor?
Great question. I have had the misfortune of seeing some aneurysms rupture in front of me. Typically, what patients will tell me is either severe abdominal pain or back pain. And so what I will usually tell patients is if you have an aneurysm and you develop severe abdominal pain or back pain, that is a go to the emergency room immediately situation to make sure that you don't have a dissection or a rupture, which, the rupture, of course, is life-threatening and needs immediate attention.
This is, again, not the time to call your friend or family member or somebody to drive you to the emergency room. This is a 911 call and getting straight to the emergency room. Back pain, abdominal pain. Occasionally patients will have symptoms of low blood pressure, so a sense of clamminess, heart racing, along with the back pain and abdominal pain. Occasionally you may get symptoms from your legs, leg discomfort if you have malperfusion of blood going to your legs. Those are the kinds of things that I would seek emergent medical care for.
In addition to those, I think every once in a while we'll have a patient who would lose consciousness, faint, and then wake up with these symptoms that could be a herald sign or initial sign of a rupture that got contained. And it is a very time-sensitive issue, as Dr. Chaudhary alluded to come to the emergency room as quickly as possible.
I think when in doubt, get it checked out. So if you think that you have warning signs, abdominal pain, new symptoms, pain that just isn't going away over where you notice your aneurysm is, or you've seen a doctor check it out before, definitely get to the emergency room. Even if it's a false alarm, it's nice to have some reassurance.
To our patients, keep sending those questions in. We will have a whole series of this Ask the Doctor, looking at all different parts, particularly in the cardiovascular segment. I want to thank you guys for joining us, and I want to thank my panel for providing their expertise in a collaborative manner. Thank you.